Let's do that. Transcript. Enable. All right. So the aim of this is for it to be very conversational. It is a guided interview. So along the way, I'll sort of like pry and move you along. So parts of it are scripted. So bear with me if I'm looking down because I am reading off of my script. So getting started, thank you for agreeing to join me for this one-on-one. As you know, the aim of the interview is to explore your lived experiences within the domains of equity, diversity, and inclusivity. Your participation in the interview is voluntary, so if at any point you need to take a break, step out, pause, stop early, you're welcome to do so. Just let me know. These interviews, as you know, are recorded with the aim of generating transcripts, and they will be anonymized. So if names get thrown out there, those will be taken out after the fact. So do I have your consent to start?
You do.
Excellent.
I have my consent to start.
Beautiful. And before we actually start, do you have any questions for me?
I do not.
So for the records, could you please state your age, your gender, and your role at the Cancer Center?
Yes, my name is Sebastian Utt. I am 50 years old until mid-July, where I will turn 51. I identify as male, and my role at Cancer Center is I'm a medical oncologist. I'm the, outgoing chair of the fellowship program and the incoming division head of medical oncology.
Who's going to take over fellowship?
Probably Kevin.
Fair. All right. So question 1 asks you to define or explain a number of terms sequentially. So how would you define or explain the term equity to someone?
Equity means, I think I associate equity very closely to fairness, and it's everyone having the same opportunities and in a given situation have the same tools, opportunities, occasions to than anyone else.
So it's about the sameness and uniformity.
Yes.
Okay. How would you define or explain diversity?
Diversity is really a grouping of, well, diversity when it comes to humans, I think I see as all of the possible variations of humans out there, whether it's relating to age, to sex, to sexual identification, to race, to nationality. And you can actually take it to across the political spectrum as well too. Diversity is really just a grouping of people among the full gamut of various views and identifications and groupings, I guess.
And then lastly, how would you define or explain inclusivity or inclusion?
Inclusivity is that despite all of the differences that people have, that all are part of a specific grouping, or specific group, and feel like they all belong.
So it's the sense of making space for people.
Yeah.
Okay. So keeping those domains, ideas, your definitions in mind, do you see these domains influencing the patient-clinician interaction? And if so, in what ways?
I think it certainly does, because I think a lot of these and how you interpret it and how you feel about them are dictated by your beliefs, your education, your upbringing, and as much as one tries to stay fully objective and open to everything and everyone, when you're having a one-on-one encounter, those come in. And I think in the clinical setting, it's clear that not everybody gets treated the same way, that there are some biases, and even though they're not open during the encounter, sometimes you'll hear comments or just not the sense that you may not go as far for someone whose identity or beliefs, or someone that's different than you may not necessarily get that extra care. I think everybody, or in large part, gets good care. I think it's to go that extra mile. Sometimes some people may need to feel this connectivity, or this connection with the patient that may not happen if someone is more at the fringes of sort of what is a normal society. And obviously, if this is not the video, I put it in quote when I say normal.
So can you draw an example? So, you mentioned the idea of having differences in, lived experience or obvious identifications or biases coming into that encounter. Can you give examples of how that would interplay in the care or the discussions had with patients?
Yeah. Example is, I have just a patient with testicular cancer who identifies as female and has not gone through, for a period of time took hormones, but has not had any surgeries or anything like that, but still identifies as female. And it has been, I hope it's not been challenging for her knowingly, but I think when I discuss her and in other people over here, there has been smirks and comments and that are not necessarily truly positive. Mm-hmm. And so to that and then also to be sensitive of a very sexualized disease, right? Testicular cancer is as male as it gets. Mm-hmm. And to treat a woman with a male cancer is it does increase the sensitivities around that, and the amount of sometimes explaining that I need to do if she needs to be referred to a specialist and various things like that.
And so what was it like sort of meeting her and trying to establish that therapeutic rapport? Was there, given, even you sort of are hearing some more insidious or maybe not fully well thought out comments about her care? Did she have any preconceived notions about what kind of care you would be able to provide her? Was there a defensiveness coming into that room?
I'm trying to remember our first encounter. I do not think so. I do not hope so. I hope that I'm a very open person when it comes to that. I think having sort of teenage kids in 2020 does help you grow in that sense, not coming from a small town, that's for sure. But also I think actually coming from a small town, I digress a bit, may help because you see a lot of bigotry in small town friends and cousins and stuff, and who you grow with, and knowing that that's wrong and that's not something, a thought process you want, you almost go the other way, trying to really be so, well, I don't think it can be too open. That sounds horrible to do that, but I think I especially at the beginning, went through more of an effort to really be open. And so, it's tough to know because young adults usually don't come to the cancer center very open. They're not too chatty to start with. Yeah. And, but I think very quickly, she warmed up because I tried to really a little bit go out of my way to make her feel like she was a woman with testicular cancer, and not with sort of a man trying to sort of cross-dress or whatever. And so I think that helped. And I think Marianne was also very helpful in that sense because she's always very respectful.
Mm-hmm.
So I think, I think it's all about respect and communication and treating people the same way. But I think it worked out pretty well.
And in terms of, again, coming into that consult, you obviously knew that this was a transgender woman who had this diagnosis of testicular cancer. Going into that room and yourself, were there any like mental stopgaps that you'd put in place, or like any thoughts of like, okay, I really need to signpost that I am ally or that I am understanding, like this is a safe space? Like, was there that sentiment that you had to go sort of out of your way?
Yeah. And I think I still do that. And I think that's where, so I think equity and equality, I think the day that you don't feel like you need to do that, I think that's where there's equality, in my mind, is because it doesn't matter. The day that we don't have to have pride, or we don't have to have, a sort of various indigenous, days and, or to me, that's where there's true equality, because it doesn't matter, right? And or Women's Day, or, that's where we get equality. I think equity is really trying hard, and that may mean sometimes you go a little bit overboard. Mm-hmm. I guess if you do go overboard, the danger is always that you look disgenuine and you're just trying too hard. I don't know. I guess we'd have to ask the patients if I do that. I also find myself doing that a little bit with First Nations peoples as well. And my African American, African Canadian sort of men as well. Some of that is also because they come in with a lot of barriers to start with. It's very difficult to initiate conversations and have a feeling like they are trusting you. So I feel like I need to sort of put myself out there a little bit more so that you develop that trust. And then it's amazing once you've got their trust. They will, they'll do anything you suggest to them because, they are trusting people, once you do get that trust. But I think probably at the beginning, I do think I go probably a little bit out of my way to make it clear that, I don't wear the T-shirt, but that I'm an ally.
And so what does that look like in terms of your practice? Like, what are tools that you'll use, things that you'll say? What are resources that you turn to? Like, how is it that you do it, right? You walk into that space, and what are the things you are doing?
Firstly is, I think, just trying to be respectful for one. Obviously, if it comes to more sexual identity, asking about preferred pronouns, and obviously when discussing sexual history is keeping it to partner and and not sexual. And I think I try to do that with everyone, period. Otherwise, mind you, a lot of the time the history is already there for us, so we already know. But if it's somebody that I didn't know, I had no history, I would say, you have a partner, and then, you kind of go from there. Partner or partners. Lost my train of thought. What was the question again?
So, I mean, because you talked about, say, your like African Canadian patients who are coming in, like, how are you, trying to put yourself forward to meet them halfway?
Yeah. I think respect the flow, and that's kind of weird to say, but often First Nations and African American are often similar, especially African American from Caribbean origins, in that they like pauses. Mm-hmm. They are thoughtful and they don't use a ton of words. And we have this tendency, especially when you're busy in clinic, to fill those pauses. Mm-hmm. And that kind of often will overwhelm them. And then they'll shut down. Mm-hmm. So kind of just slow it down a bit. is what I try to do, and ask them what sort of things they like, and then foods and whatnot, just sort of, try to find some things that make them tick, and then spend some time talking about that. Mm-hmm. If we're certainly, First Nations, having Dina there is very helpful. Mm-hmm. I think, Dina, likes me, so I think the patients already get this kind of thumbs up, and they feel a little bit more secure. But also, they have an ally there. They have, a true ally there. And it's really just speak to them and not at them, and not think that they're idiots because they're, they live on reserve, and just get them to explain to you what they think is going on, and then kind of form a partnership. So it's the same as what you do with everybody else, but I think you just need to adapt a little bit for who they are, and that's no different than speaking to, sort of other ethnicities as well too. You need to be sensitive to how they operate.
Absolutely. And so in your reflection, clearly you're speaking to a lot of mindfulness and conscientiousness in your practice. Have you, either as a staff clinician, witnessed in a colleague, a learner, or thinking back to your training, had a preceptor that you worked with who did it very poorly that stands out in your mind as an example, or someone who did it incredibly well?
Yeah, so I think most of the people there's definitely some that did it poorly, but I can't recall that the people that did it poorly were that much better with, kind of a generic middle-aged white person. I think people that have not great skills, maybe even worse in more marginalized populations, but I don't think they're awesome with anyone. So I think what I recall there is more just not, I have not, thankfully, not seen anybody openly being, mean to in front of someone. I'm thinking that this is the very, very minority in oncology, because if you've got this little patience for people, then it's not the right job for you. But certainly in clinics, for sure, I've heard, people, nurses and physicians, and not trainees. I can't say that I've heard any trainees, and weirdly, and we'll see whether that changes with my new role, but I've been guilty of not saying anything, right? Of not saying, that's not cool. Actually once, but I think if I ever heard a trainee do that would be something that we'd have a pretty significant conversation about, and in part because I think if a trainee is here, whether you're directly, teaching that person in your clinic or not, they're in a learning environment, and if they're like this, then that's not appropriate. But if it's your colleague, that's a lot more difficult. Or at least I find it a lot more difficult, and I've been a bit cowardly at that.
So how do you affect a culture of change where people feel more comfortable calling each other out?
Yeah. I think I'll tell you in a couple of years in terms of how that can be built. I think it's just, I think trying to set a process or a program where you can say something without it. So there's a lot of preconceived, and then a lot of people will say jokes that are off color, and not because they're mean people. I think that's just what they've always done, and it's not cool. And you can say something to someone without having to, be a big, huge deal, that it goes up the chain, and there's ramifications and there's punishment. Obviously, if it happens over and over again, then that's not good. Mm-hmm. But I think both the person that points something out and the person that gets something pointed out need to be under the understanding that, yeah, thanks, you're right. And then the other one said, no problem. I think that environment is what needs to happen. It cannot be a punitive environment, and because nobody is going to want to punish their colleagues, and then nobody is, and then people are not going to take it well if it's a very negative interaction.
Sort of pivoting a bit. So, you mentioned all of these things that you conscientiously try to do. In reflection, either as a staff or as a trainee, were you ever given any formal training within these domains, whether they were labeled as EDI or not?
So yes and no. So as a trainee, heck no. I trained in the 90s, and so we were like the Browns University open posture was out there as a technique for interviewing, in terms of interviewing skills. So that is, that's not that. This said, I was part of the first year of a new curriculum in Ottawa, where there's a lot more emphasis on diversity than there had been in the past. So I think that was always a good part of that. As a physician, I know there's not been a whole lot of, there's CMEs, but none of us have to do it. I'm on the board for Hamilton Health Sciences Foundation, because I had some free time, and we did have EDI training for that, which was interesting. But because the whole board, the foundation employees were getting trained, and the board members were also asked to be formally trained.
What did that training look like?
A lot of sort of play situations kind of thing. Obviously, some on paper documentation, but I think a lot of that is more role play.
Mm-hmm. And was that effective?
It's a good reminder. I'd like to think, and I think that's probably a good thing, that it didn't really teach me a whole lot. It reinforced, obviously, things. But I think if you're already fairly mindful, hopefully it doesn't. If it teaches you a whole lot, then it's like, oh Christ, you have to look at what you were doing for those periods of time. I think I think it was helpful. I'd say I think most of what has helped me, formed me, has been more my home life than anything. I have a partner who is a female physician training in the 90s, and that's tough to do. So, she certainly made it very clear what the inherent biases were towards women in medicine and nursing in medicine. And I used to be one of those that say my nurse, well, not for a long time, because Catherine just hit me over the head with a hammer every time I would say my nurse. It's like, she does not belong to you, just like no women or no people belong to you. But just things like that. And then more recently with children, especially my youngest one, in terms of sensitivity to EDI, to pronouns, and to that whole world of identifications that is obviously a little bit foreign to my age group and older, but it is important to realize.
And so
I'd say most of my training has really been at home. Mm-hmm.
So exploring that a bit more. So you're saying, obviously as you stepped into positions of leadership or sought out opportunities for more in the abundance of free time that you have, that these opportunities became available to you. But would you say that in your day-to-day clinical environment, there wasn't really any intervention, programming, or teaching?
I agree. I would say that, yes.
And so you've mentioned that a lot of this was learned, obviously, in your home life as well. When, in recollection, can you think of the time that there is a realization in yourself, like maybe not under the terms of like, oh, equity matters or diversity matters, but you're just like that sense of like, this clearly impacts people, it should matter. And I know that earlier you shared growing up in a small town. So what was that learning experience like?
Yeah, I think I don't want to obviously kind of label myself better or worse than anyone when I was growing up, but I think, it starts very early, right? I think in a home situation, I think respect was always a big thing. So my parents always, we did not ever tolerate, the racist jokes or the N-words or in a lot of the kids where I grew up, including some of my cousin, everybody that's slightly brown or darker is a Paki, right? And to me, that was always an abhorrent word, right from the get-go. And I guess in a way kind of wants you to do better. Sometimes, seeing things that just don't mesh with you help that. Mm-hmm. So I think that's been more that than anything else. And I think family members, I think my dad has at least one, probably two or three. He has 7 sisters, so that are, openly gay. And I think that's been good for everybody. My parents are good Catholics, and, gay people and Catholics don't really get along. But, it's very different. It's weird that somebody's thinks it's so wrong until it's your sibling, and then all of a sudden it's kind of okay for that person. And then as they evolve a little bit, then it's, realize, well, it's not just her. It's, everybody's just, it's the same. Yeah. So I think it was more that than anything.
And, you mentioned how with your family and your daughter, there was learning edges that you were exposed to, like say with people's identities and their pronouns and things like that. What was the emotional journey of facing that? Like, was it always a welcome, like, this is easy, yep, this is what I got to do? Or was it ever uncomfortable and strange and frustrating?
Yeah, it depends, right? So I think it's very weird because it's very easy for me to see someone with different pronouns or different identities that is not my child. It's always very difficult, or not very difficult. It's more difficult when it's not your child. And I think a lot of that, I think there's 2 things there. One is your own ego. You want to have your kid being like, the kind of poster child, kind of normal in bracket, kind of, cereal box kind of kid. And then when that's not, then that's, it's a kind of you may see it as a reflection upon you. And 2 is protectionism. You just want to protect your kids. And if they're a little bit different than the norm, that it might be a bit more difficult. Mm-hmm. So that's why it's a little bit more, but I think that's where it's even more important to, to sort of go that extra mile. And then, I guess that's where I think having a good partner helps you to sort of remind you about you're being overly, kind of judgy, or you're, be careful of the words you use. And then you take that and then you bring it to your own practice, and that's a lot easier. But it's always toughest with the people that are closest to you. And then if you can do that with the people that are closest to you, then you can do it with everyone, I think.
So when you think about the fact that, so much of it is experiential and living through it, how do you bring it back to a space of training, knowing that not everyone is going to have the opportunity for those experiences, is not going to have the same intrinsic motivation to do more? How do you homogenize training in a way that is palatable to, say, trainees or even mid-career staff?
I think it's to bring it back to personal experiences for the person. And yeah, not everybody will have, a preteen kid that, is working on whichever pronouns. And I'm not saying that to be facetious. I think the pronouns do change. Kara's still trying to figure that out. And, but even if it's not something like that, everybody has personal experiences. And then it's, a little bit like what you're doing today in terms of, asking people for their own lived experiences. And I think we think of EDI very much going to those extremes of sexual identification, but it could be as simply as having interactions with Indigenous peoples or people of color, or, heck, it could even be Jewish people. Like, I grew up having seen zero Jewish people. There was one black person that I knew until I was like 17. And that was as ethnic as I could have. Like, you kind of, but we all have these lived experiences. And then I think having people reflect on how it was and whether in today's lens, not to be judgy. I think that's the other thing, is you can't judge actions 30 years ago with today's lens, and then because you won't get people to move forward, they'll just get defensive and anchor down. But just think, is this something? What would you do differently if you were the person now? Then what sort of things would one do differently, and then give the tools to sort of continue to do that. I think it's to bring it to the personal level. I think to me always helps, because that's where, and there's also sometimes people need to, it's the right time. I don't think I was always like this. Not that I'm perfect or nearly. But I'm sure I was not as open then as I was now.
So when you think about it pragmatically, so now, in your capacity and role as head, in your capacity as a preceptor who works with learners, and knowing that we exist in a CVME paradigm and that no one has time, right? Like, time is a non-existent entity. How, in a perfect world, would you design training or programming that can be taken up by trainees and by staff?
Oh gosh. I think it has to be short snippets more frequently over a longer period of time with lots of refreshers. And then I think the staff, it's a little bit more difficult, because the learners, it's fairly easy, because I think there is a lot more sensitivity to that, to EDI now than there has ever been. And as you move up, it's to continue to think that way, and not, okay, I've learned it in first year med school or second year, and I'm, going back to being a jerk. It's to actually have those refreshers. So I think it's smaller amounts more frequently. And probably the same thing, I guess, with staff. Certainly there's probably even less time for staff, I think eventually I certainly see it that it is a part of being hired, is to at least have a, part of a course or class, and then, every year or two you need to have a refresher, of some sort. I also don't think that online, works very well, and certainly not a passive online. Whether it's a active Zoom type online where you're an active participant, but watching a video will not. Because if you're not interested, you're just going to do something else while the video is playing. We're all very bright people. You can all answer if there's a quiz at the end. And EDI is not about quizzes. It's about sort of the way that you think. And so there has to be active participation. I don't think that anything passive, other than perhaps some of the pre-reading, is appropriate. And that's difficult. People don't like to talk about how they feel, or, how you approach someone with sensitivity. I think that we don't do that very well. At least some of us don't do that very well. I also think, though, that some of that is organically changing, and we're organically changed, right? There's more than 50% of medical trainees are female. And I think talking about feelings a bit, and being a little bit more emotional in your thinking and your behavior will rub off, right? And because it normalizes it a lot more. I think it'll be from it'll go away from the women having to be as tough as the men, in the way that they think and they speak, or at least they portray themselves, to being more the opposite. It'll be actually the males that get into medical school and become physicians are the more sensitive ones that actually can, because soon robots are going to be able to do the surgery the surgeons do, and robots can sure as hell do most of what I do, because, a lot of it is, there's recipes, there's regimens and things like that. But what's never going to go away is the interpersonal relationship that we develop with patients. And I don't think that that will ever go away, but it'll become even more and more important, because knowledge itself, you can get, at the tip of your fingers. Everybody can be a Google Doc, and to be a real doc, you still have Google. So,
yeah.
That's where it's going to come to as well with regards to medical school admission reform. And unfortunately, we don't have a good way now. You kind of weed off everybody that's not a 4.0 GPA, doesn't even get an interview. But I was thinking of that last night a little bit, because I saw that we had the interview, but I would not have gotten in. Well, actually, probably too, because Aiden is applying to various programs. He didn't get into Queen's Commerce, and he's got a 97.8 average. And so these averages are just so high. You have all these really smart kids out there. Some of them are inflated, but that's inside. It's easy to find smart people.
Yeah.
But I don't think it's, I think emotionally smart people is going to be a lot more important. And that's what we still don't have a good way, I think, of figuring out, in terms of, getting, the right people into medical school. I think a lot of the time we get it right, but not everybody.
Fair enough. And just being mindful of the time in the last little bit. Can you recollect a time when, irrespective of like the patient experience, where you have been on the receiving end, where someone did not take the time to acknowledge or, even respect your diverse needs, the space that you came from, your personhood, didn't include you, or, wasn't equitable in their interactions with you, that affected you personally or professionally?
I'm a wealthy middle-aged white man, right? So, I know how, and also of some, I've been around long enough, and I think I have the respect of enough that I got it good. So I don't think so. I really can't recall that. I certainly see a lot of my colleagues where it happens too. I try to, when I get asked to chair a meeting or give a talk or something like that, I usually give examples of other people that could do it. There's very few GU female oncologists, but there's some really good ones, and try to suggest other people like that. I can't say that I've, people make fun of me about being French Canadian or tease me about being French Canadian. That doesn't count. Like, that's really just teasing, talking about poutine and stuff. Like, if I have to complain about that, then that's, it's worse than first world problems. So I really don't think so. I also don't open myself up to a lot of that, in the sense that, my home life, private life is my life, and it's not, I don't sort of shout it to everybody. So, but yeah, I think I can't recall that
And would you say that within the division and department, safe space is one way to label it, but do you feel like there is a culture of accountability, of vulnerability, where people feel like they can be their most genuine selves, but also be regarded in that manner? Or do you feel like there's still a culture that needs to grow?
I'm not going to be evasive, but I'm going to tell you I don't know. And I don't know for a few reasons. One, I think COVID and the fact that we've not had it's very easy to be cohesive and on Zoom, right? It's just, you don't have the personal interactions, and that's been missing over the last few years. And that's usually where you find the clashes and the people being, insensitive. I think a lot more. I guess it's social media. Yes, but we don't do any of that. But I think within our division, I don't know we've had enough interactions to really know that. The other thing I don't know about is I am not aware of a lot of people who are a little bit marginalized. And the way I'm going to quantify that is people of color, women, Muslims, which are often sort of marginalized populations, are not as marginalized within medicine and within oncology specifically, and within our division especially. So it's been more normalized. It's a bit more of a normal occurrence. So I think there's less discomfort there. But what would happen if we had someone that was sort of transsexual or identifies as another gender, or we've not had very openly very gay people. It's been, so sometimes you can say, oh yeah, everything is perfect, but if you don't test the system, then you can't tell that it is. So I think when we do have people with sort of special, or not special, but with slightly different identifications, I think that's where we'll really test whether we're tolerant and accepting and an equal kind of group or not.
And in your role as head, are there any goals or truly, goals that you've set for yourself that you'd like to see done during your tenure as it relates to EDI?
Yeah. It's certainly sort of optimizing or increasing the voices of the people that are less vocal. For, obviously if they want to. If you want to stay in the shadow, then that's okay too. And certainly when there's hiring opportunities, is to take that into consideration. And also starting to have more interactions with one another. Because I think we think of EDI sometimes at those extremes, but EDI is just the people around you as well too, because it's who you're living with and spending a lot of time with on a day-to-day basis to be, to feel like you're all you're all part of the same kind of family in a way. So I think that's really what I'm trying to get. And also, it started to a tiny degree with my communications is to really focus on, positivity and respect and constructivism. I think it's okay to I don't want to use the word complain, but it's okay to voice an opinion, but there's, you can be an a-hole about it and be very negative, but that doesn't help anyone. Or you can sort of try to be more constructive, kind of, this is what I feel is happening. This is what I'd like to sort of do to try to work on making it better, not just this is stupid and then fix it. Well, that doesn't help anyone. And so I think it's more that I want to work on. And just, I think if you have happy, people that feel fulfilled and feel accepted, then it's a lot easier to be acceptant of others, and be more open to, to sort of, to everyone.
And in the last couple of minutes, are there any points of discourse that you want brought up as it relates to the overarching research question, which is understanding how oncologists learn about and understand the domains of EDI?
No, I think we talked about it a fair bit, but I do think that it's a lifelong process. And just like, I find it's kind of stupid that ACLS happens in, I don't know, even like med school even. But there's no refreshers. I could not run a code now to save my life because it's changed 10 times since then. the same applies to the principles of EDI. I think you need to have those refreshers. Now maybe we're living it a little bit more often, but not really, because most of the people are, you end up going back to, you revert to the mean, right? You revert to what you're comfortable with. And so to have smaller bites often is more important than having a big meal of it less often.
For sure. And any other points, any other takeaways that you want for the record?
No, I think, other than the fact that I think oncology being a more sensitive specialty to start with, because we deal with people who have very grave issues, and we're there with them as they, stop being alive, and often, I think we're maybe a little bit further ahead than others, but that doesn't mean that we need to rest on our laurels, and we should be sort of leaders in that and continue to do so.
Beautiful. And with that, I will stop this recording and